Again, in Act 1, the first pivotal trial with Tisabri, you have it available. We don't in Europe. But again, the trial, their primary endpoint was negative. And the ITT population, you can see that here, gray is placebo, blue is Tisabri. But again, if you enrich the population by increased TRP and having immunosuppressives on board, you see that there's a difference between the two groups. And again, it's a placebo response that is going down. Now, you could argue with me that, well, maybe Tisabri and certolizumab-pegol are not the most efficacious short-term biologicals for Crohn's disease. There's no real data to show that, but it could be the case. And it's never been shown for anti-TNF agents outside of clinical trials. Well, there you have SONIC. Okay? In SONIC, on the left, patients with a normal CRP giving infliximab is a waste of money. There's no significant difference over azathioprine alone. Whereas in those patients with an increased CRP, there you see the delta of infliximab monotherapy, infliximab combo therapy over azathioprine. So also for other anti-TNF agents such as infliximab, we don't have data for adalimumab as of now clearly in clinical trials, but I suspect it's the same thing. What are we showing? Anti-inflammatory drugs work best in patients with inflammation. Okay? It's a no-brainer, but we didn't have any clear data until now. So what have we learned from clinical trials? Those trials are not clinical practice, and you all know that. You're all having a lot of patients in clinical practice, so you know that. And we know that symptoms may fool us, and it's becoming more and more clear. We have to be careful about this. The biological outcomes, and this will be the theme of my next slides, biological outcomes such as CRP, and I'll switch over to mucosal healing, what they do is improve the signal-to-noise ratio in the clinical trials. By anything, they're doing that. But we need validation of what they really mean, and that's going to be my second theme. Clinical trials stop at 8 weeks, and the disease doesn't. I mean, I know we have longer trials now, but the pivotal induction trials for EMEA, for FDA are 8 to 12 weeks. But that's just a second for a patient, right? Randomized controlled trials, I'm not going to come back to that, but we've seen that a lot of side effects popped up with biological therapies after the RCTs were done, but I'm not going to discuss that. But we have to be honest, there's no alternative to randomized controlled trials at this time for testing new drugs. We shouldn't leave that path, by no means. So are there new therapeutic goals in IBD that we could look at? For patients, I think the clinical endpoints short-term is what matters. Induction of remission, off steroids, permanent closure of fistulas, no more drainage. But also the long-term course is important for a patient. Avoidance of complications, hospitalization, surgeries, this is what patients are concerned about. And of course, avoidance of mortality, so we have to keep our drugs safe. Now the question is at the level of the bowel, is this just some spielerei for the doctors, or is there something more to this, right? Is complete mucosal healing of all involved segments important, or is it just something that we like to show because we like to scope? Well, again, at onset, SONIC, if anything, SONIC learned something, is that CRP, but also lesions, are important to make a drug work. So again, if patients had no lesions at endoscopy, they were not having any benefit for infliximab. So you see the middle panel there, there's no difference between the 3 bars, infliximab combo mono or azathioprine. So CRP story comes back with endoscopic lesions. So there's something to that. And what about mucosal healing in Crohn's disease? Should we ever look at that? Well, if you look at a panel of our drugs, glucocorticosteroids, this is an ongoing debate. You know, there's negative data from the French JEDED group that corticosteroids are not very good healers of the mucosa. There's some indirect data that they may do that. But for the sake of argument, let's classify them for Crohn's disease amongst the drugs that are not causing a lot of healing. We do know that azathioprine 6-MP are slow healers, but they do heal the mucosa. It's less clear for methotrexate. Okay? The last data from France and other, I think from Spain also, are indicative of the fact, but they were not well controlled, that methotrexate is quite a poor healer of the mucosa, but we need prospective data on that. But for sure, we do have good healers, rapid healers. We forget about the children here, and we've seen in trials that exclusive enteral nutrition does induce mucosal healing in children. I know in the US it's not used a lot, it's more used in Europe, but we have to go by the trials. It does induce mucosal healing. And the 3 of our anti-TNF agents have been shown, some of it a little bit more conclusively in clinical trials, some of it in open label, but it seems to be that they're all healers of the mucosa. This is data for azathioprine. This is a JET trial reported first by Marc Lehmann, who unfortunately died a few weeks ago in gastroenterology, and by Xavier Tréton afterwards in clinical gastroenterology and hepatology. This was a discontinuation trial with azathioprine. But why I'm showing it to you today is just because the investigators also looked at the baseline endoscopy. So all these patients were at least 4 years on azathioprine and were in clinical remission. So they looked at their patients and tried to find out how many of them were actually in mucosal healing with azathioprine. Well, a little bit more than a third if you use the strict French criteria of a CDAS below 4, so virtually no lesions, about 46%. No ulcerations, and I'll come back to that. This is probably a very important endpoint. No ulcerations, 54%. So about half of your patients with azathioprine in clinical remission will have no endoscopic ulcers. And of course, I don't have to show you this slide. This 95, 96, when we were treating the first patients with Infliximab, this was something we'd not seen before. Dramatic healing with submucosal fibrosis on the right-hand panel, and you see that also the histology turns almost back to normal in 4 weeks' time. This was unheard of, and we thought we have a new class of therapies. But the question is this relevant? And we see that complete mucosal healing, which was absence of ulcerations, was also better with maintenance therapy than with episodic strategy. And in 2010, it's again a no-brainer. We're giving maintenance therapy to most patients, although there are still jurisdictions like in the UK that are promoting episodic therapy. Well, for mucosal healing, it's not working very well if you do that. So this patient I'm presenting to you, a lady who was born in 1959, you see that her Crohn's colitis was not responding to azathioprine. She was in clinical remission with adalimumab, normal CRP, and at the ileal colonoscopy, we saw complete healing of the terminal ileum and the colon just a year after she started adalimumab. And just for those of you who are not treating a lot of IBD patients, this is what we're seeing. And it actually projects quite well here. And I've got a pointer. Hope I don't kill anyone. Yep. This was an ulcer before. You see the hostrations are interrupted. And this was a serpiginous ulcer before. And this is what you see, also pseudopolyps. And we don't care a lot about these pseudopolyps because they don't seem to hide some malignancy. So this is a patient with a complete response, mucosal healing to an anti-TNF agent. But could have been azathioprine too. You can see these images with azathioprine. So I told you this patient was under adalimumab, and this is a trial that's released. For adalimumab, you see that the primary endpoint was not met in the EXTEND trial. A trial, it's actually the first trial looking at mucosal healing as a primary endpoint. But overall, I think you have the impression per protocol and also over a longer period that yes, also adalimumab is probably a good healer of the mucosa. I'm not showing you the detail about the data with certolizumab. This was open label data, so take it with a grain of salt. I'm just showing you that deep ulcerations in 31% that were still present, but you see that the deep ulcerations are going away with the therapy, and you see more and more superficial ulcers, but no ulcers. It's only the minority of the patients. So does this mean that UCB is not a good mucosal, the Cimzia is not a good mucosal healer? We don't know. We need more data. And this was also an open label trial. So I think the jury is still out on that.